All right, good morning. My name is Suzanne Palmer, and I'm from the Johns Hopkins Applied Physics Laboratory. And I have the great pleasure and honor to be here with Vice Admiral Rocky Bono, Vice Admiral and Dr. Rocky Bono, who leads the entire Defense Health Agency. So we're going to take about 30 to 40 minutes this morning and just share with you some of our perspectives on the challenges associated with healthcare and healthcare systems that don't work together, and talk about some of the opportunities that we see in terms of connecting systems and how that can help improve efficiency and outcomes for patients. So just to give you a little perspective in terms of where I'm coming from, I mentioned I'm from the Applied Physics Laboratory. This is a separate part of Johns Hopkins University from the medical school, but we work very closely in this space. But the Applied Physics Laboratory is actually a systems engineering organization. So we build large-scale complex systems, and we do things like send spacecraft to Pluto, if you guys remember any of those really cool images from a couple of years ago. And we're about to launch another spacecraft to the sun this summer. So we do everything from space through air, land, sea, and under the sea, which is where I spent most of my career. So the first 18 years of my career were spent developing advanced capabilities for our submarines. I'm an electrical engineer. And so when I started working in health, one of the things that I needed to get smart on was what are the major challenges in healthcare, and how can a place like APL bring engineering capabilities and expertise to improve healthcare. So I just want to share with you a little story. My very first experience trying to get smart on what the challenges in healthcare are had to do with a tour of a cardiac catheterization lab. So as many of you know, a cardiac cath lab is where you go in for this procedure. It's not open heart surgery, but it is messing around with your heart, so kind of important.
Okay, so clearly you can tell she's not a doctor, right?
I'm
just going to put that out there.
Yes, you're going to see that today. But so as a double E who spent her career working on submarines, coming into a cardiac cath lab, it looked kind of like, a regular operating room. And the clinicians talked through the procedure that they perform there. So they have this catheter that gets inserted through the blood vessels, works its way over to the heart, and they, look at the function of the heart, make some measurements, look at the arteries, see if there's any blockage, make some real-time decisions about whether angioplasty is needed or some other kind of procedure. And as they're describing this, they're talking about some of the data they're collecting, right? So they're taking x-rays, there's a little camera at the end of the catheter so they can take video and look at what's going on with the heart. So I'm getting super excited and like geeking out on wanting to go see what they do with all this data. So after we kind of get a sense of the procedure and talk about all these things, we go over to where the computers are. And so I'm really excited at this point, and I want to see what they're doing. So they pull up an image, and they start kind of showing what we're looking at. Here's the artery, and here's what you can see, and all these things. And so I asked what I thought was a straightforward question about data fusion. I said, so, can you pull, do you use data fusion? Do you take x-ray data and what you're getting off the video and all these things and put it together to form a more comprehensive picture of what's going on in the heart? And, I might as well have been speaking a foreign language. They just kind of looked at me like, what in the world are you talking about?
It was that third eye in the middle of her forehead that brought that response.
Right. So I was like, okay, data fusion, maybe that's a little advanced. How about some simple tools, right, that can help you make certain measurements or identify maybe where there are some problem areas and sort of help the doctors and the nurses focus on the things that were most critical. And, again, I'm talking through, and they're kind of looking at me like, what in the world are you talking about? And then they finally said, oh, yeah, we have tools. And, they pulled out their state-of-the-art mouse and trackball and proceeded to show me how they can, point and click on the artery walls, and sure enough, a number pops up that represents the distance between those 2 points. And so that was like a really interesting learning experience for me, and it really, kind of showed me what my mission in life was going to be, which was to figure out how we can take all of these advanced capabilities, which, all these things I'm asking about are not super advanced. They're sort of, basic engineering and algorithm development. And we have way more advanced capabilities in other areas. So I wanted to figure out how can we take all this great technology development that's been done in other industries and bring them to healthcare to help improve efficiency and effectiveness of care. And so, that's kind of where I'm coming from. But as you can imagine, Admiral Bono has a very different perspective. So.
Not that Suzanne's perspective is any less. I mean, I was pretty proud when she got to the part about the click ball, the mouse and the click ball. I mean, yeah. But let me just, so I think that's a very unique perspective. Do you mind if I ask, how many of you are in healthcare? Okay, how many of you are in healthcare and IT? All right, how many of you are with the vendors? Any of the vendors in here? Okay, so here, what you're going to learn here is what you need to say to the vendors, okay, because that's the whole part, that's what our talk is all about. So as Suzanne said, I come from it from a slightly different perspective, but what she just set up for me and shared with you is exactly the piece that I was experiencing from the medical side. A couple of things about me. I'm a surgeon by training, a trauma surgeon. So I'm used to a lot of chaos, and I'm used to navigating through that. But to put on top of that, not only am I the director of the Defense Health Agency, where we look at the healthcare across Army medicine, Navy medicine, and Air Force medicine, I also happen to be in the military. Oh, this is for mood lighting. Okay, so y'all feeling real relaxed now? I know that I have a couple of slides here that I just kind of want to show you where I'm looking at interoperability and how it plays out for me. Because we take the military health complex, we're looking at medicine and both the military aspects, which are two very complex areas, and bringing them together. But what we have in here is we have to be able to deliver care down at the pointy end of the spear, down in the battlefield. And oftentimes what we've got down there in the battlefield taking care of our wounded warriors, or as first responders, are techs, medical enlisted technicians, who are oftentimes a corpsman or a medic or a med tech, who have the requisite training to do the resuscitation, but we need to make sure that we're capturing what's happened downrange. Because at the next point of care, we have to get them back to where we can offer them definitive care. So what happens in the battlefield, and then oftentimes when we transport them in the back of a Black Hawk helicopter, which is very analogous to patients being transferred or transported in an ambulance. So how do we capture that care, and how do we keep track of that, especially as we bring them to the higher echelons of care, whether we go to the back of a very large airplane where we have an ICU set up, or when we eventually get them to a fixed facility, an MTF. And so all of this equipment needs to somehow interface and make it so that we have that fidelity in our data about what's happened with our wounded warriors as they're going forward. But for me in the military health space, it's even more than taking care of people in uniform. It's being able to take care of them once they transition from their uniform and oftentimes into the VA or other parts of our environment or our society where they need to get additional care. So again, being able to have that integration and that interoperability of our health data, our health systems is extremely important. Now, in addition to the veterans, then we also take care of family members. And so in the military health system, we have nearly 10 million beneficiaries. We have over 350 hospitals that are across CONUS, continental United States, and overseas. So there's a real imperative for us in the military system to know how to keep track of this kind of data. So as we're looking at this, the other part of it that is a big driver for me as I'm looking at what we can do to improve this interoperability is how well can I also keep that information secure. Because as being part of DoD, I have a heightened awareness of cybersecurity. Now, I hesitate to say this in front of the crowd, and if you repeat this and you attribute it to me, I'll probably have to come seek you out, okay? I'm just fair warning, okay? But part of the reason we're sensitized in DoD about cybersecurity is we know what it's like to be constantly cyber attacked. But you should also know that your military is very well versed in how to be a cyber aggressor as well. So we know where some of those opportunities are, and we also know that the military space is not the only space where we are at risk for cyber. So I want to put that out there, and I hope that there's somebody out there who'll challenge me on that, or challenge us, or want to engage in that conversation. So as we go through the military health system, what you'll see is that we're very much a microcosm of the healthcare environment for the United States, for our nation. And because we have a relatively large presence, we are, as a healthcare system, we're the 7th largest healthcare system in the United States. We hope to be a part of the conversation with the rest of the healthcare environment so we can make progress in moving towards better interoperability. And then one other part of my intro here is that you've probably also heard a conversation about how DoD, the Department of Defense, and the VA, the Veterans Affairs, are going to start partnering. And I think this is incredibly important because now we're talking about over 20 million beneficiaries whose data we're going to be sharing across DoD and VA. And being able to have that interoperability with the VA is going to be exceedingly important for us. And as we combine our healthcare systems, that's also going to elevate the size of what our healthcare in the DoD, in the federated ecosystem will look like. And I think the thing that's very exciting about that is moving towards that collective decision-making and aggregating that decision-making power. And just to give you kind of a baseline of what kind of numbers that means is that for my healthcare system, it's a $50 billion a year industry. And for my equipment replacement, my life cycle and equipment replacement, I'm usually spending about $1 billion a year. I don't know if that's the right amount, but I think that this is something that I would hope that industry and vendors would pay attention to. So I look forward to some of the comments here, but I know that Suzanne and I have some other things that we're going to be talking about. But if it's okay with you, if you guys want to interrupt us, feel free. Okay?
Yeah,
Because truth be told, I want to learn from you.
$50 billion a year in spending, and you spend $1 billion on CapEx for infrastructure. What's the rest?
So mostly personnel and our infrastructure. Also, what we also do is a good portion of that is actually I purchase care from the civilians. And so that's a great question. Thank you for reminding me, because that's another interface of interoperability that is exceptionally important to me.
Yeah, so as you heard, Admiral Bono has a vast space to worry about and very complex challenges to deal with, not only interoperability and commonality across the United States, but internationally. But the thing that I wanted to spend just a few minutes talking about is the fact that we don't even have interoperability within a single room right now, right? So we're thinking about, across hundreds of hospitals and clinics, we don't even have it within a single room. So one of the experiences that really kind of hit home on this topic for me, in addition to the cardiac cath lab story, working in the ICU with Dr. Peter Pronovost, one of our colleagues, who's an intensivist. As soon as you walk into an ICU, the first thing, at least, that struck me were all the alarms going off, right? That's we've all heard about this. And the fact that nurses respond on average to a false alarm every 2 minutes, right? So as you think about that, again, this is within the ICU, so you have the most critical patients in this area. You're responding to false alarms. That's a huge efficiency issue, but also over time, those things are going to just be drowned out, right, in the background. And I understand that every new system or every new device that's developed, they work really hard to make sure their alarm is the loudest and most annoying of all of them, so that they might get a response. So not only is it a problem for the clinicians, but what about the patients, right, who are supposed to be recovering, and there's constantly alarms going off everywhere. So one of the simple ways to address false alarms is by looking at multiple sources of data. And again, you're going to hear a common theme here. But bringing together different sources of data and using some very basic logic and algorithms to make sense of those is a really easy way to bring down false alarms significantly. But what does that require? It requires you to be able to share that data, right? So we need to be able to develop systems where you can actually aggregate this data from different systems in one place so that we can work to do things like beat down false alarms. So, I mean, everybody in this room probably has a different example, right, of how we could do better by combining data. So there's an endless number of examples. But, from the technical side, it's not that hard. And that's the part that's so frustrating, I think, is that when you look at this from a technology standpoint, we know how to do these things. And I think that's one of the areas that Admiral Bono and I have spent a lot of time talking about, is that we have proofs of concept, and we can talk about that a little bit later on. But this isn't a technical challenge; it's a cultural challenge. It's regulation, it's policy, and it's the fact that healthcare is not a centralized industry, right? So there isn't that one decision maker, that one authority that can say, here's how we're going to move forward, here are the standards we're going to use, here's how we're going to exchange the information. And so that's one of the reasons that I'm so excited to be partnered with Admiral Bono, because as she discussed, the 7th largest health system in the country, that's a force, right? And that's a way to try to drive things in the direction that we need in order to help figure out how we can have interoperability across our systems.
And, having been a critical care intensivist, a surgical trauma surgeon too, I mean, I know what those alarms are, and they can be annoying, but being able to make them relevant and something that you need to respond to is something that I always was frustrated with too. So it's gratifying to know that the technology is out there. If I can kind of expand that aperture just a little wider too, in terms of this interoperability. So within our healthcare system in the military, I have over 118,000 IV infusion pumps. That's a lot, and that comes from 11 different vendors. And so now you're starting to talk about, okay, well, what would we need to look like, or what would we need, or what kind of decisions would we need to make to get to that better interoperability? So here's the other thing that's happening in the military health system, is we're also launching our new electronic health record. Now, I know there's a lot of competition out there, and so I'm going to go ahead and just tell you that we got the Cerner product, and I know there are probably some Epic people out there, but our big thing, and I wish there were more vendors here, because part of what you want to pay attention to is how DoD is migrating towards more of the commercial solutions. And this is an important driver for us now in terms of setting up our health IT and our digital environment. Because now, as I look at those IV infusion pumps, I want to make sure that those infusion pumps actually interface with our new electronic health record. And as Suzanne was describing to you, in an ICU, ideally we want all of those medical devices to be communicating with each other. I mean, what a concept, right? And I earlier brought up the part about security. Ideally, I would also want to be able to have these medical devices that sat on my electronic health record and talk to each other, to also have the kind of cyber programming that's necessary to keep that data secure. So as I'm looking at that, and I'm trying to figure out what kind of decisions should I make as a director of a very large healthcare system in terms of what kind of medical devices I should be putting on my system. And then another aspect, for those of you that are involved in this, being able to select medical devices, and in this case infusion pumps, that are interoperable or that interface with our electronic health record system, that also talk to the rest of my medical devices, and that also provide a level of security that I need. Now I can also start tailoring the training that I need, because the piece that I'm also looking for, and I showed you a couple of slides on this, is how well does that IV infusion pump get ruggedized enough that I can take it downrange to use in our hospitals, in our MASH units, or our fleet hospitals, or our hospital ships. And what kind of benefits or efficiencies could I gain by having the same type of IV infusion pumps that I train our folks on in our hospitals that are in the United States, and then when they get deployed to go downrange, they encounter the same medical devices, and I don't have to worry about the training. And then finally, and when I went through medical school, I would have never thought that I could hear myself talk like this. Now, in terms of my life cycle management, I now know I can start predicting what kind of tech refresh and what kind of replacement cycle I should use for the replacement of my infusion pumps. So it's a much larger conversation, but I think what we're trying to get here is paint the picture that part of this is a very large ecosystem in which everybody has a role, And it's how do we aggregate that, and how do we move towards more collective decision-making?
I'll admit that I've worked for several vendors over my long span in healthcare. And I grew up in the financial district when we went through the same electronic combinations and fusion. We had greed, so we moved a lot faster. But here's my question. You are the 7th largest healthcare system, and working with vendors for my whole life. If someone came up to one of my companies, and I'm sorry you didn't choose, even though I don't work for them, they have great interoperability, and said, I would like to use your system, but these are the standards of communication we are going to have to use. I can't believe that Cerner or Epic or GE Centricity or whatever you want to pick would not switch over and customize for you, and you could leave the standards. Have you tried or thought about that?
Yes.
That is exactly what we're doing.
Yes, that's exactly what we're doing. And that's actually what brought us together, is that in procuring our Cerner, we actually put in our RFP, our request for proposal, those types of requirements. And as a matter of fact, Cerner was the first electronic health record system to get a DoD ATO, authority to operate, because we had set that as a requirement for our security. And so when we did that successfully, and we started looking at the other parts of our health care system, this is when I met with others at APL saying, well, what could we do to drive that behavior in the market? And so as I'm looking at medical devices and as I'm having my industry days, I'm being very upfront with, here are the 3 things that I'm looking for. And I'm not interested in buying a proprietary patch. And you already know, based on the numbers that I shared, that we move large sums of money to make this happen. So I would hope that would be something that people would pay attention to. And so I kind of alluded to it, not only are we a microcosm of the healthcare environment, I believe that the military health system can help inform and shape the way the healthcare system will evolve. In the military health system, our doctors work for us. I mean, they are part of. We also own the healthcare plan, and almost all of our patients, they start off with us, and so we've got the 3 legs of the stool for healthcare. And I'm very interested in partnering not only with industry, but universities and thought leaders to figure out how can we create some of those drivers to create that change. And so that's exactly what we've been doing, is working on how do we set the conditions that when we move into the marketplace, we're letting the vendors know this is what we're looking for, and we need you to do this because of X, Y, Z.
That makes sense. If your Medicare, Medicaid, and the defense would all make us have a standard CDA, then your rural practices help the VA and people who feel would all be talking the same language, and it would be utopia.
Yeah, if I could just
Yeah,
add
no,
on
please.
to that, I loved your question because that is exactly where we came from in terms of this approach. But I'll share with you that in talking with some of the leaders on the civilian side, when DoD knows how to do RFPs and how to say these are our requirements, right? On the civilian side, not so much. So when we started talking about, you should say, here are our requirements, and we require these communication standards, we require interoperability. And the response was, why would they listen to us? They just show us what they have, and we kind of pick from what they have. We don't really tell them, exactly what we need, and then they're not going to change what they do for us. And so again, as you rightly pointed out, that's where the military health system and the DoD can really help drive that forward. And so we're excited because
let me just take it a step further, and then I'll take that question next. Because not only did we set that up in our RFP, because of the way the Defense Health Agency is structured, part of my portfolio is also the logistics, the medical logistics. So once I find, and I'll just use IV infusion pumps as an example, once I find that sweet spot of the 4 or 5 IV infusion pumps that meet all my criteria and that I can really start optimizing the training and the life cycle management, that's all I'm going to put on my catalog for logistics. So when hospitals go to order the IV infusion pumps, they're going to get a drop-down menu, and they're going to have those 5 ones that, or whatever that final figure is. Exactly. Now, as a surgeon, I also know what that's like in the OR. For those of you that run ORs and do the supply and equipment of ORs, that would also mean that we would not have like a gazillion laparoscopic sets. You would have the few that actually do what we needed to do, and then we can start targeting our training and making sure that we sustain that. Yes, ma'am.
Isn't the problem really that the vendors want to maintain their barriers to entry so that if everything becomes interoperable, then you can replace them, and they don't have a lock on the market, so it's in their interest to continue to keep things proprietary and not allow this massive interoperability, because then if you have everybody's infusion pump works together, then what's the difference if you get it from vendor A or vendor B or vendor C?
I know competition sucks, doesn't it? I mean, yeah, that's right. So, and I think that's one of the things that we're actually asking for from the healthcare leaders, is that let's get together on this so that we can drive that kind of level of performance that we actually need. As a provider, I know how it is to be approached by the vendors and be shown the next shiny object. But that kind of appetite needs to be channeled towards a more enterprise solution.
Yeah, and that attitude is certainly what we've experienced in other sectors that transition from sort of,
We had Wang, and then you had IBM, and then everything was standardized upon one thing, because the most R&D research went behind it, and it was the best product.
Right. And so that's what, creating these open standards allows for increased competition.
Right.
It allows for the small companies to come in and present their best solution that can be integrated into the system. So that's certainly something that we're expecting. But I think industry sees that this is where things are going, because we had a conversation a few weeks ago when we were talking about, there are lots of standards out there, right? You're probably all familiar with FHIR and HL7 and all these things, right? So there are standards out there, and the discussion is shifting toward interoperability. And we actually had some heavy hitter industry reps who were saying, hey, just tell us what you need. We're happy to design to whatever requirements you give us.
Yeah.
And that was surprising.
That
at least for me.
Yeah.
So.
But I think that was encouraging too. So I think that, yes, and I didn't mean to denigrate in any way competition. I think that's great. And yes, I think that as we move towards that, then it should raise the bar for everybody, and that should then be able to give us some choice. But I think the other part of that is how well, as a sector of this society and the market, how well can we come together and aggregate our collective decision making to drive some of this change?
Yeah, so one of the other, the other considerations, there's been a lot of talk of interoperability at the electronic health record level, right? And so we kind of talk about it at different levels. That's sort of at the macro level, exchanging data across health systems with the electronic health record. But I think, a lot of what we've talked about today, when you drill down to the patient-facing medical devices, that seems to be a more difficult situation, just because, as Admiral Bono said, there are so many systems out there, and everybody has their favorite.
Yeah.
And so it's not only the challenge of just creating the standards, but it's also trying to get to some level of commonality. So particularly for the DoD, as you train on one system, you're not having to learn a different system everywhere you go.
Yeah.
So I think there's a scale, and there's a breadth of challenges all the way from EHR to EHR and down to medical device interoperability and sort of everywhere in between. Another one of the things that was, astounding to me was, I learned that within a single hospital, nurses spend on average 90 minutes tracking down a prescription that was ordered, right? So a doctor puts in an order for a prescription, and it gets filled, and it's delivered to one of like 3 or 4 places in the hospital, and there's no way to track that. So we're not just talking about things that are directly, patient-facing or EHR. There's even the different components within a health system where, logistics, supply chain kinds of issues can be simply fixed if we had better communication across these systems.
Yeah. I think that the opportunity is just, and I'm sure many of you are sitting there thinking, since you've come from healthcare, you're thinking of a number of examples where there just even a little bit of streamlining would make not only your life but the patient's lives a lot easier. And where we're trying to go with all of this is elevating all of our performance so that we can provide that reliable, more safe environment for our patients. We become so large and clunky And while technology drives a lot of that, it's being able to coordinate that and bring that together and integrate it in a way that's meaningful for our decision making and meaningful for our patients' participation in care. And I think that's where we all need to, state that as our starting point, and then ask ourselves, what do we need to look like? And then the second question is what do we need to do in order to get to that? And one of the things that's very exciting about what we're doing in DoD is finding ways that we can work with a lot of different people outside of the military. Because we know, especially in the military health space, we don't have all the solutions, nor do I have the personnel or the talent within the military itself to find all the solutions. So I've been increasing that interface with industry, and I have numerous industry days, but I also specifically target small businesses because I think they have really creative solutions, and what I try to do is find ways that they can come work with us and start scaling some of their things to see if we can't translate that across a much larger environment. So I've actually set up here in Austin with DIUX and other small startup places where they're very innovative and very creative in moving towards giving them an opportunity to work with us and seeing what kind of solutions we can find. I think that part of what we're up against is how fast can we do this? How well can we make this? How quickly, how agilely can we make these decisions and start changing our environment? And I think there's a lot of interest out there, and you guys seem to represent part of that healthcare that can help us create that momentum.
Yeah, so I just wanted to give one example. We've talked about a lot of the challenges and I think some of the possibilities, and I really feel like there's hope. We've done some proof of concept, prototype development and deployment. One of the ideas was maybe if we can demonstrate the value in interoperability, that would be another way to kind of push the community toward adopting, standards for interoperability. So we actually, back to the ICU, we spent a lot of time focusing there, and we actually developed a system. It's called Emerge, if anybody wants to look it up, EMERGE. But we developed a system that was focused on addressing 7 patient harms, preventable medical harms, which of course everybody knows is the 3rd leading cause of death in the US, right? So we developed a system that was basically a dashboard, and it ingested data from the electronic medical record, and it also ingested data from all of the sensors and systems within the patient rooms. And the point of this was to create better situational awareness for the clinicians in the ICU. And so it had this dashboard display that was really intuitive. It's kind of a red, yellow, green that shows you which patients are at risk for particular harms based on the various care that's been provided. And so rather than going through pages and pages and pages of Excel files, right, in the health record to try to dig this up, everything communicated with the central system. And so we deployed it in 2 separate hospitals and collected data over a 6-month period. And we were kind of worried because, in 6 months, obviously it's a redundant system. We couldn't go in and replace anything. So it's a redundant system. And we thought, well, in 6 months, are we really going to be able to see some measurable differences, with this system deployed versus without? And we were amazed. We actually found significant increases in efficiency in terms of clinicians' ability to both identify patients at risk and then identify when they hadn't gotten certain required interventions. And then we were also able to measure improvements in outcomes. So we were really excited about that. There's a paper that's going to come out soon with all the details. But, that was one example of how at a micro level, we were able to demonstrate the value. So I think between, the immense need and the community kind of recognizing the value and then having some demonstrated results that show that value, we're hoping that we're going to change the tide here. I also share that optimism. I think there's a growing interest in this from not only the healthcare side, but from the consumers as well. I think our patients are really going to be the disruptive innovators, and we need to pay attention to what they're saying and what they're asking of us, and really get our minds wrapped around what does a healthcare system look like, or how does it need to be designed in order to be responsive to what our patients value. Assuming that all other things are kept equal, and in terms of outcomes and safety. To go along with that, as another example, being able to use our medical data to get to that predictive
space. They're predictive for populations and individuals, and then also to be able to help mitigate some of the risks that we see. And I'll use the opioid epidemic right now as an example. We did a proof of concept looking at all our data, but because I shared with you that many of our patients are taken care of in the private sector, being able to access that and combining it with our data in terms of opioid prescriptions, we've been able to identify which providers are most at risk for providing the types of prescriptions that put our patients at risk, and more importantly, we can tell now with a great deal of sensitivity which of our patients are most at risk for developing the addiction. So that allows us to act at a much earlier time in their care. But we had to be able to do that by sharing data across some interoperable interfaces between private, commercial, and DoD. And then the other part of that is pulling our patients into it. So there's a tremendous amount of opportunity here, and I think it depends on the appetite that we have to addressing it. And so we hope, and we were very excited to have this opportunity to speak to you guys, because we think that there is this growing interest, and hopefully what we're trying to do is create more momentum towards that. So I'd be willing to hear what some of your thoughts might be, or any of the questions or examples that you might have, because I think that what also is also helpful for me anyway, and I know that we talked about this, I learn a lot more from the audiences than I think that I give to the audiences. So I'm interested. Some of the questions that were here were very good, and the things, the initiatives we're working on are certainly going to be shaped by what I hear here.
Very, very good discussion now. I really support you on the overall view. Okay, we have to combine everything in the world. But on the other hand side, my experience, if you don't start in the small cities and the small areas, you will never end it at the global view. Yes. So we have to do both.
Yes.
And I think you could do within DoD a lot more things independently than together with others, and even quicker, because you are the master of the data. And if you use AI and whatever, you can use many things. And this is what I would prefer, if you could do this and go forward and then take the others with you. That would be my way for getting healthcare really to the next level of technology.
I agree with you, and I'll add that to my to-do list. You're exactly right, and that is actually part of the approach I've been trying to use here, is that I see our military health system as having what we were talking about earlier this morning as a corporate social responsibility. And part of that corporate social responsibility is contributing to our society. We do that in kind of a mega fashion. I mean, it's not a secret that with some of our mass casualty events in the United States, Boston Marathon bombing, Las Vegas, Madigan or Washington State with the Amtrak accident, Sutherland Spring in San Antonio, in all of those instances where there were mass casualties, DoD was there to partner with that, and the care and the things that we've learned on the battlefield have translated very well into the civilian healthcare space. But you're absolutely right in terms of our role in helping to shape and inform how healthcare could go out into, shape the private and commercial place. I had attended about a year and a half ago, or maybe it was closer to 2 years, a seminar up in MIT. And I was listening to thought leaders and healthcare leaders about some of their challenges, and I thought that's the same thing that we're experiencing. And what I offered to the group was that please watch the military health system, because I believe we can help find some of those solutions. Now, 2 years ago, didn't get much of a response. Today, I'm starting to get more of a response, because I think that people do recognize that we can help shape some of that, both in opinion and in action. So I appreciate that. Thank you.
Good morning. Hi. It's wonderful that this is getting so much attention, because it's so apparent that the fragmentation of the electronic health record system is a problem, right? There's over 700 EHRs in our country alone. So this pilot is wonderful, but I'm just curious because I've spoken to other military physicians and know quite a few, and they're always like, yeah, the military healthcare system is always 5 steps behind what other technologies are. So are you able to compensate for that? Do you believe that that's actually the case, or?
Thank you for bringing that up. I think it's real easy to fall into some of our institutional habits, and this gets to the conversation about what does your culture allow you to do. And in order to create that culture, my feeling is this is where where leadership, healthcare leadership, is very critical, because you need to have that at the top helping to drive some of this down while you're also creating some of the solutions and the progress from below. So to your question, yes, I think that we can turn this much quicker. We have a lot of dedicated interest in this, not only in the military health system, but as you may suspect, my real boss is actually in DC, and there are a number of them who have a very strong interest in making sure that we're creating the most effective and lethal Department of Defense, military. And so with that kind of impetus and that interest in reforming what we're doing, I think that we can turn that pretty quickly. The Defense Health Agency is in a very unique position to drive that.
And if I could just offer a slightly different perspective on that problem, because at the Applied Physics Lab we work both with civilian and military health systems. And what we found is that there are a number of areas where civilian hospitals are leading, but then there are also some other areas where military health is leading. And one great example of that is value-based care. So, everybody's heard about that. That's like the new buzzword. Well, the DoD has actually done it, and we've implemented a pilot that's now being scaled across multiple facilities. And so we've kind of taken that out of theory and put it into practice and demonstrated a lot of value and improvement there. So I think, there are probably examples also where the reverse is true, but there are definitely some areas where we see military health leading the way. So.
Good morning. I'm probably one of the few physicians in the room, so it's great to see you, Dr. Bono. Appreciate everything you do for us. I come from a different perspective. So I'm a physician whose career path has taken him in the direction of creating his own small business, and I went back and I got an MBA because a lot of things that you talk about today resonate with some of my frustrations as a doctor, not seeing things from engineering and other more systematic approaches coming into healthcare, and we see the opportunity there. You talked about the statistic on the third leading cause of death. I mean, to me, that's a shame that we have a tremendous healthcare system, and we are some of the best physicians in the world, and yet we have a culture generally, and I'm speaking to my own kind, of being resistant to change. At the same time, I think I have a very specific viewpoint on technology, and I argue that technology should be a tool, right? And many times I think we let technological advancements or the opportunity to let a technology improve healthcare, we let the tail wag the dog. I mean, ultimately it's about providing better care, and it ultimately has to be a tool that's usable and it's effective for the physicians to be more efficient and to provide, be able to spend more time taking care of the patient. And believe me, I'm an advocate for technology as opposed to many of my counterparts that are, dead set against, using EMRs or any other technologies that might actually improve efficiencies and interoperability. I know it's a necessity. I'm an early adopter of most things. And at the same time, though, I see that, there's a challenge because operating, and I'm local in Austin. There's competing healthcare systems, there's competing politics, and so every effort that I've seen come up from any angle, whether it's university-based or private industry-based, has been thwarted by ultimately politics and whose market share it is, and that's frustrating. I know you guys see that too, but I think I guess to end my point, it's not really a question, it's kind of a commentary. Is you talked about it earlier. You have all 3 legs. And I think that's a vital standpoint, where innovation can really come from, where you don't have competing interests. Theoretically, you have one goal in mind, which is save money, improve healthcare, and improve patient outcomes. And I think that's a unique position for you guys.
Yeah.
Yeah, actually, what you described is something that I'm very passionate about. So technology should be there to help support the clinicians and the patients, right? And help provide them with better information, better decision-making tools. And I think what's happened, at least in a lot of areas in healthcare, is, like you said, it has been the tail wagging the dog. And so one of the things that we try to focus on is, what is that end goal? What is the thing that the clinician needs, the decision maker needs? What information do they need in order to be able to do their job? And then let's design the system around that. And I think that's what's, part of what's broken right now with healthcare is we have all these tools out there. The electronic health record is just one example that there's lots of people have frustration with. But there's lots of tools out there that are just, here you go, here's another tool. And it's not necessarily taking into account the environment that it's going to be used in, all the other tools that it needs to work with, and how we can leverage all those pieces to best support, the end user. So that, again, that's a very systems view of things, but that's one of the areas that we're trying to work on and improve.
But along that, and adopting that systems view, I think is extremely important, and that's really the collectiveness that we need to get to. I mean, you shouldn't be left out there by yourself trying to do this on your own, honestly, right? We should have an ecosystem that supports this no matter where you are, in the small rural areas to the large medical centers. It needs to be part of the continuum, it needs to be part of the shared space. And that's where we need to move towards, because we have the technological answers, but they ought to be designed in a very thoughtful way.
First, I want to add on to that absolutely, as software vendors for healthcare, we go in and best of intentions. I've seen this for 10 years. We ask you what you want. The dynamic is changing. We are now going in, working with you as partners to find out what you need.
Right.
What is the question you're trying? Because typically what happens is we want this, this, and this. We're like, okay, fine, we'll build it for you. We can build anything. We get there and we shoot right over what they were actually trying to solve. And it could have been much, much simpler.
Right.
We as vendors have to get more involved in partner versus our beautiful product people that are in a box, theoretically thinking what's best for y'all, because until you're in an operating room or in a patient's office, you don't know.
Right.
You don't know that second click is going to be the one that stops them from putting information in because it's a pain in the butt.
Right.
It's just how it is. So agree with that. We're trying. We're waking up, but we were a little egotistical for a long time about we knew better than the people who are providing care.
Well, and I think part of the challenge, though, at least what I found also, is that when you go in and say, what do you want? You kind of get a list of things that are around the current processes and workflows,
the way it was done.
right? So here's everything I do, help me do it faster, as opposed to there might be a different way to do it that's better,
exactly.
right? And so
Yes.
that's what we're trying to help provide, is sort of that vision of here are the possibilities. What if you could have this? And then they say, oh yeah, we'd like to have that, right? So I think it's a combination of opening people's eyes to the possibilities and then helping them develop the capabilities to get there, because you don't know what you don't know. And so, we're going to continue along the same path if we don't start having.
And there's a lot of times when people will be like, well, why do you do step C? We've always done step
right,
C.
exactly.
Right, exactly.
Okay.
So along those lines, and this is extremely important, now this is where the science is so important. I mean, we can design these systems with data, and we should design these. The challenge, though, that we have in the healthcare area, and as a physician, but it applies to any clinician, is our willingness to change how we do certain things, and not necessarily accept or be willing to challenge that just because we've done catheterizations this way all the time, is that the way we need to do this going forward, given the technology and the knowledge that we have today? And I would argue that that's actually a part of the conversation that needs to be had up front before we look at all these elegant solutions, is figure out, is there a more effective way of doing it? And then with the vendors and industry, is helping us with your data to show why a particular system re-engineer makes much better sense than the way we've been doing it.
And my actual question that I got the microphone for was, I've noticed that you've done some internal build versus some buy. What are your criteria for that, and when do you decide which option is the best one to go with?
I think it's a combination.
Yeah. I mean, from my perspective, if there's something off the shelf that's going to solve the problem, start there. And
Yeah.
you need to reinvent the
Right.
wheel. But for some of the capability that we've developed, it's where we've looked around and we've looked at what's there, and we take where we can, and then we build around it where, a capability doesn't currently exist.
Yeah. Yeah, and that's what I mentioned earlier, is that we're going with more commercial in DoD, so we're starting there. And the largest challenge of that is the change management.
And how far does your customer experience, the patient experience, weigh into purchasing innovation decisions?
Yeah. So for us in the military health system, large. It's a big part. It's a driver that we're really trying to get at more frequently, more consistently, and more comprehensively. In my mind, for the military beneficiaries, for our beneficiaries, our DoD beneficiaries, my going in is this is their healthcare plan. And so I want to understand what is valuable to them, what creates value for them. And I think it should be a given for them that, if they come into any one of our facilities for surgery, that they're not going to have a complication, that they're not going to have an infection, that they're not going to be readmitted, that they're not going to die. That should be a given. So understanding what creates value for them in that healthcare episode or in their healthcare experience writ large is a big driver for us. So what you're going to see in the military health system is we're working on our access, our ease of getting into some clinics or appointments. The other piece of that is empowering them with their own data and making sure that they have that is their data, and that we're partners with them. So the patient experience and their value system is what we're taking into account largely as we reconfigure our military health system. Great. Oh, there's one more.
When one is trying to do these interfaces and integrations, thank you, a lot of it honestly boils down to hard work. So in other words, some of it is just how you decide, which partners you're going to work with, and no matter what you pick, there are things that you're going to have to change, and there are things you're going to have to work with. So do you mind speaking a little bit about how you decide which partners you're going to pick with that sort of work ethic in mind, and if that plays into how you decide who you're going to work with?
I've become very discerning about who I give the taxpayers' dollars to. They have to share some of our values, and they have to share our goals. I'm a steward of a very large sum of money. And it's critical to me, to the previous question about how well we're designing this healthcare system for our patients. And so I'm very selective about the vendors that we work with.
Thank you. I'm a physician as well, and you just mentioned the patient experience, and that's one thing that we're really focusing on in my institution. And another challenge that I've been working on is trying to improve the fit between a patient and the provider. And so I wanted to hear, what is the DoD currently doing in terms of when there's a patient with a certain condition, how do you find the right provider and to improve that fit? Yeah. And what does the future look like for the DoD?
That's a great question. And I think, the way healthcare, the complexity and of healthcare, the space itself, our environment, the complexity of our patients, it really does take a team approach. And what I'm looking for and what we're doing in DoD is making sure that our providers, all clinical providers, are team members. And that's something that we've demonstrated how well that works, especially in Iraq and Afghanistan, with our survivability of injuries, is that we find that when we brought all the services together and combined our collective expertise, we had one of the lowest fatality rates, despite increasing injury severity scores on the battlefield. So that is a part of what we're doing, and that is it's actually a continuum that we're working on in terms of the providers that we bring into DoD.
So I think we got the sign from
I know,
the back.
we're kind of getting the hook here. So.
Thank you very much for your
Thank you.
questions and your participation.
Thank
Thank you so much.